Hi there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I urge you to sit back and spare me part of your very precious time to share with you some very useful tips which may prove handy in your line of duty. So I welcome you to part 86 of our pharmacotherapy MCQ series majoring in basic oncology. Our first question reads, Mrs. PWN, a 32-year-old nulliparous female patient, presents to her gynecologist for checkup. She has never had an STD and has been in a monogamous relationship for slightly over 6 years. She has never been tested for HPV, neither has she had the pap smear test done. So my question to you is, which of the following would be the most appropriate method of cervical cancer detection basing on PWN's age and history? Would it be A, HPV and cytology co-testing every 10 years? Or would it be HPV and psychology co-testing every 5 years? Or is it true that no screening is indicated since she has no risk factors? Or is it cytology alone every 5 years? I'll give you 10 seconds to choose the correct answer. So I would settle for HPV and cytology co-testing every 5 years. Now HPV and cytology co-testing is preferred every 5 years for women aged between 30 and 65 years. Now cytology alone is also recommended as acceptable in this age group, but if you opt to use it alone, it should be every 3 years, not every 5 years. That makes answer D wrong. Then regardless of this lady's history, screening is still indicated for her age. So answer C is wrong. It is only women in the bracket of below 21 years where screening isn't recommended. I would like to add that cytology alone is never recommended every 5 years, but every 3 years for women aged between 21 and 29 years, or is acceptable for women aged between 30 and 65 years. I'd like to remind you that HPV and cytology co-testing is recommended for women aged 30 to 65 years every 5 years and not every 10 years. So remember that, it's very crucial. Now, criteria for cervical cancer screening vary depending on the age of the female patient, as is recommended by screening guidelines and even joint collaboration by the American Cancer Society, the American Society for Colonoscopy and Cervical Pathology, and even the American Society for Clinical Pathology. They are in agreement. And the fundamental goal of cervical cancer screening is to prevent morbidity and mortality from cervical cancer. And there are 2 recommended screening methods for ages 30 to 65, as I said. They are either HPV and cytology co-testing every 5 years, which is the preferred, or cytology alone every 3 years, which is called the acceptable alternative. Just like to add that HPV and cytology co-testing the lack of greater benefits, and even the increase in potential harms associated with screening more frequently support a recommendation for co-testing every 5 years. So don't do it very frequently. Let's move to the next slide, please. And it reads, Mr. RPR, a 38-year-old male with past medical history of Crohn's disease, type 2 diabetes mellitus, and hypertension, presents to your clinic. It was recently disclosed to him that his 64-year-old father has confirmed rectal cancer. And Mr. RPR is obese. He smokes 1.5 packs of cigarettes daily and enjoys eating beef or steak. He spends most of his evenings watching television in his living room, and he seeks to know from you or from your team if he has any risk factors for colorectal cancer, which is his dad suffers from. So my question to you is, which of the risk factors listed below does Mr. RPR have for colorectal cancer? Is it hypertension, red meat consumption and watching television? Is it a family history, Crohn's disease and cigarette smoking? Is it Crohn's disease, hypertension and obesity? Or is it smoking, hypertension and family history? I'll give you 10 seconds to choose the correct answer. It is family history, Crohn's disease and cigarette smoking. Now remember, Mr. RPR is at an increased risk because of colorectal cancer, family history, Crohn's disease and even smoking. His additional risk factors include obesity, low levels of physical activity. Remember, he views a lot of television, red meat and high fat consumption, and even type 2 diabetes mellitus. Those are associated with a poorer prognosis of colorectal cancer. It's recorded in literature. Now, hypertension isn't a risk factor for colorectal cancer. Just like to add that risk factors for colorectal cancer include inflammatory bowel disease, smoking, red or processed meat, high fat diet, alcohol consumption, type 2 diabetes mellitus, low levels of physical activity, even metabolic syndrome for those who have it, and obesity. So when counseling these patients, emphasize those risk factors. Let's move to the next question, please. And it reads, Mr. DAK, a 67-year-old white male patient residing in Texas, received a diagnosis of advanced stage hepatocellular carcinoma, abbreviated as HCC, at your oncology clinic. He has a past medical history of hypertension, type 2 diabetes mellitus, high cholesterol. He is an IV drug user or abuser, and he drinks 2 to 3 beers every 2 weeks. His aunt was diagnosed with hepatocellular carcinoma at the age of 74 years. So my question to you is, which of the risk factors listed below is most likely to be associated with HCC in Mr. DAK's case? Is it hepatitis B virus, hepatitis C virus, history of HCC, or excessive alcohol consumption? I'll give you 10 seconds to choose the correct answer. So hepatitis C virus is the correct answer here. Now, risk factors for HCC include cirrhosis, HBV, HCV, excessive alcohol consumption, obesity, type 2 diabetes mellitus, non-alcohol fatty liver disease, what we abbreviate as NAFLD, even inherited liver disorder, and aflatoxin exposure. Now, DAK has a history of IV drug use, therefore he has a higher risk of HBV or HCV infection. Now globally, HBV is a leading cause of hepatocellular carcinoma incidence and mortality. Now the US has a good surveillance program, and they have an HBV vaccination program, and that has resulted in lower incidences of HBV infections. Now in the US, the incidence of HCV is increasing, particularly in the HCV infected patients. Now DAK consumes 2 to 3 beers every 2 weeks. Therefore, in my opinion, excessive alcohol consumption is less likely to be the cause of his hepatocellular carcinoma. He doesn't really consume much. And his aunt had a history of HCC, but she isn't a first-degree relative. So that makes answer C wrong. Thus, HCV is the most likely cause of hepatocellular carcinoma in the case of this gentleman. So that makes answer B the correct answer. Let's move to the next question, please. And the next question reads, Mrs. NTN, a 51-year-old female, undergoes matched sibling allogeneic hematopoietic stem cell transplant at your hospital following a relapsed acute myelogenous leukemia AML. Your oncology team has administered busulfan and cyclophosphamide to her as a preparative regimen, followed later by methotrexate and tacrolimus for graft versus host disease prophylaxis, what we abbreviate as GVHD. Now NTN also needs to begin her prophylactic antimicrobials. So my question to you is, which of the prophylactic antimicrobials listed below will interact with tacrolimus? Is it Depson, or is it levofloxacin, marketed as Levaquin, or is it posaconazole, marketed as Loxafil, or is it valaciclovir, marketed as Valtrex? I'll give you 10 seconds to choose the correct answer. Posaconazole or Noxafil it is. Now tacrolimus, which is marketed as Prograf or Hecoria, is a calcineurin inhibitor used to prevent graft versus host disease in allogeneic transplant patients. It is a substrate of CYP3A4 isoenzyme and even the P-glycoprotein efflux transporter. Now, I'd like to emphasize that levofloxacin and valaciclovir don't utilize these pathways for their metabolism, and Depson is a substrate of several CYP450 isoenzymes including 3F4, but it doesn't significantly inhibit or reduce it. Now posaconazole, Noxafil, is a very strong inhibitor of CYP3A4, and it would be expected to increase the tacrolimus serum levels grossly, and that would lead to toxic levels. Let's move to the next slide. And it reads, Mr. B.O.B., a 45-year-old male patient, is day plus 72 after allogeneic hematopoietic stem cell transplant. According to your lab, he is seropositive for varicella zoster virus, what we abbreviate as VZV, and even herpes simplex virus, HSV. So my question to you is, which of the agents listed below would be the most appropriate for prophylaxis in the case of Mr. B or B? Would it be acyclovir 400 milligrams orally twice daily? Would it be moxifloxacin 400 milligrams orally once a day? Would it be acyclovir 800 milligrams orally twice a day, or would it be no routine antibiotic or antiviral therapy is indicated? I'll give you 10 seconds to choose the correct answer. I would settle for acyclovir 800 milligrams orally twice a day. Now, all patients with seropositive VCV and HSV are at risk for viral infection. Now, antiviral prophylaxis helps reduce viral infection or even reactivation in this particular cohort of patients. Now, antibiotics or antibacterial agents will not be helpful, as the goal in this case is to reduce the risk of viral infection. So moxifloxacin would serve no purpose. That makes answer B wrong. Now, acyclovir is the best choice in this particular case. Now, 400 milligram dose is appropriate in non-hematopoietic stem cell transplant patients. I would just like to remind you that higher acyclovir dosing, that is 800 milligrams orally BD, is required for high-risk patients like patients undergoing hematopoietic stem cell transplants. Now, virus serology negative patients don't need acyclovir prophylaxis. Let's move to the next question, please. And it reads, your medical oncologist decides to treat patient NTP, a patient diagnosed with testicular cancer, using ifosfamide. So my question to you is, which of the adverse effects listed below does ifosfamide cause in such patients? Is it pulmonary fibrosis, conjunctivitis, hemorrhagic cystitis, or is it red cell aplasia? I'll give you 10 seconds to choose the correct answer. So it does cause hemorrhagic cystitis. Now, ifosfamide, marketed as Ifex, is converted to a urotoxic metabolite called acrolein, ACROLEIN, which can bind to the bladder wall and produce hemorrhagic cystitis. Now, cyclophosphamide, on the other hand, is another alkylating agent that is also known to form acrolein, and it can also cause the same adverse reaction. And Mesna is administered, or its administration is recommended around the time of ifosfamide administration to prevent the occurrence of this adverse effect. It is usually given at the same time as ifosfamide in a dose specific to the ifosfamide dose. Let's move to the next question, please. And it reads, to what class of monoclonal antibodies does panitumumab belong? Is it the humanized, chimeric, human, or mouse? I'll give you 10 seconds to choose the correct answer. So human it is. Now, panitumumab, or Vectibix, is a recombinant, fully human IgG2 kappa monoclonal antibody that binds to the EGFR, epidermal growth factor receptor. Now, there are suffixes before the mab which signify which class or group they belong to. So the suffix U signifies a human type of monoclonal antibody. Let's move to the next question, please. The next question reads, what role does tumor protein 53, abbreviated as either TP53 or P53, play in tumor drug resistance in relation to chemotherapy? Is it true that A, wild type P53 is associated with increased resistance, of the cancer tumor to chemotherapy? Or is it true that mutated P53 is associated with increased resistance of the cancer tumor to chemotherapy? Or is it true that mutated P53 is associated with increased susceptibility of the cancer tumor to chemotherapy? Or is it true that P53 doesn't affect cancer tumor drug resistance? I'll give you 10 seconds to choose the correct answer. B is correct. It is true that mutated P53 is associated with increased resistance of the cancer tumor to chemotherapy. Now remember, P53 is a tumor suppressor gene, and it's often mutated in cancer. Now, overexpression of mutated P53 with reduced functionality is often connected to resistance to standard medications used in chemotherapy. I'd like to remind you that mutated P53 is associated with an increased resistance of the cancer tumor to chemotherapy and not increased susceptibility. Now, wild type, which is the unmutated P53, actually suppresses tumor formation. It doesn't increase resistance. Then I would like to mention that P53 is a well-known and studied tumor suppressor protein that is associated with tumor resistance when it is mutated, leading to a loss of function. Now, tumor suppressor protein P53 suppresses tumor formation and renders protection against DNA damage by inducing cell cycle arrest, DNA repair, and even apoptosis. Now, this P53 pathway is often mutated in cancer, and it results in impaired tumor suppressor function. And overexpression of mutated P53 is often connected to resistance to standard medications, which include cisplatin, the alkylating agents such as temozolomide, the anthracyclines such as doxorubicin, the antimetabolites such as gemcitabine, and even the anti-estrogens such as tamoxifen, and the EGFR inhibitors like cetuximab, for example. Let's move to the next question, please. And the next question reads, Mrs. AMT, a 47-year-old female patient, regularly receives her cancer chemotherapy at your oncology clinic. In Mrs. AMT's previous cycles of chemotherapy, she developed significant reductions in white blood cells, the WBCs. Your oncology team is now administering Fieldgrastim to her. So my question to you is, which of the white blood cells is increased by administration of Fieldgrastim or Neupogen? Is it the lymphocytes, eosinophils, neutrophils, or the basophils? I'll give you 10 seconds to choose the correct answer. So it increases the levels of the neutrophils. Answer C is correct. Now, Fieldgrastim is a granulocyte colony stimulating factor and is commonly used in oncology. It primarily works on neutrophil production and maturation, and it shouldn't be administered within 24 hours before or after cytotoxic chemotherapy administration. That would be a waste of resources. Let's move to the next question, please. So, is it true or false that rasburicase and allopurinol shouldn't be administered concomitantly? I'll give you 10 seconds to make a decision. It's false, and I'll tell you why. Allopurinol and rasburicase can be used together since they lower uric acid by different mechanisms. Allopurinol inhibits uric acid formation by blocking what we call the xanthine oxidase. It's an enzyme, and unfortunately it doesn't affect circulating uric acid. Rasburicase, on the other hand, quickly lowers uric acid levels by converting uric acid to what we call allantoin, Allantoin. Now, by co-administering rasburicase and allopurinol, there is a potential to use a lower rasburicase dose and even to lower the duration, since the formation of new uric acid will be inhibited. Now, the approved rasburicase doses range from 0.15 to 0.2 milligrams per kilo IV daily for 5 days. However, there are many small studies describing positive experiences with a single dose of 3 to 6 milligrams of rasburicase administered stat. Let's move to the next question, please. And it reads, Mrs. DDW, a 54-year-old female patient, presents to your oncology clinic with symptoms consistent with the diagnosis of chronic myelogenous leukemia, what we abbreviate as CML. The team has ordered a cytogenetic workup. So my question to you is, which of the cytogenetic abnormalities listed below is Mrs. DDW likely to have? Would it be the translocation 15 semicolon 17, or 14 semicolon 14, or 9 semicolon 22, or 8 semicolon 21? I'll give you 10 seconds to choose the correct answer. The abnormality is likely to be a translocation 9 semicolon 22. I would like to start by saying that the Philadelphia chromosome, or translocation 9 semicolon 22, is diagnosed in over 95% of patients with CML. Now, in this translocation, an ABL gene from chromosome 9 is translocated and fuses with a BRC gene on chromosome 22. And this gives rise to what we call the BCR-ALB1 fusion gene. I'd just like to emphasize that translocations 8 semicolon 21 and 15 semicolon 17 can be seen in patients with acute myeloid leukemia, and it infers a good prognosis. And then the translocation 4 semicolon 14 is a poor prognosis in patients with multiple myeloma. Now, CML is characterized by translocations 9 semicolon 22, which leads to the Philadelphia chromosome. Just as by the way, let's move to the next question, please. And it reads, Mr. AKM, a 39-year-old male patient, is receiving a matched unrelated donor allogeneic hematopoietic stem cell transplantation HSCT for aplastic anemia. As the clinical pharmacist based at the oncology clinic, the hematologist requests you to educate Mr. AKM regarding the signs and symptoms of potential graft versus host disease. So my question to you is, which 3 organs listed below are the most likely to be affected if Mr. AKM has acute or delayed graft versus host disease? Is it the gut, skin and lungs? Is it the liver, gut and skin? Is it the lung, liver and gut? Or is it the skin, the liver and the lung? I'll give you 10 seconds to choose the correct answer. B is the correct answer. It's liver, gut and skin. Now, a typical patient undergoing graft versus host disease post allogeneic hematopoietic stem cell transplant can present with skin rash, with diarrhea, and even elevated liver enzymes. Now, these abnormalities are due to graft versus host disease affecting the skin, the gut, and the liver. Now, these symptoms are typically confirmed by a biopsy in patients like Mr. AKM here, who have undergone hematopoietic stem cell transplant. Now, lungs aren't likely places to have graft versus host disease, so that makes all the other three wrong. So my highly esteemed viewers and listeners, that brings us to the end of this video. If this video benefited you in any way, I would like to remind you to give it a thumbs up, to like it, and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. So thank you very much for viewing this video and for listening to me, and I appreciate your partnership, your continued support, and your kind collaboration, and I look forward to interacting with you all in the next video. Thank you very much.